Hello, my name is Jay Huang. I'm a junior pathology attending in the United States, and I go over general pathology from head to toe almost on a daily basis. Recently, I haven't posted because I'm in military basic training, and it's been busy, but I got some free time. Without further ado, thank you to Pathlibrary. Um, this is a very interesting case. So we have a scrotal plaque in a 60-year-old male. So we have a pretty wide excision of scrotal skin that contains the subcutis, as we can see with the fat. But I think if I were to put a reason as to why there's this plaque, it's got to be the epidermis and maybe superficial dermis. I mean, you can see like maybe a hint of maybe like hyperkeratosis, but this could be due to tangential sectioning. So let's look closer. I mean, you have compact hyperorthokeratosis and parakeratosis. So that could be due to infection, like tinea. And then you have the epidermis. There's a little bit of acanthosis, but I mean, I would say overall, not really acanthotic. There's kind of like a lichenoid band of chronic inflammation with a neovascularization. So what could be the cause of this plaque? So let's look closer. So we have a kind of somewhat thickened granular layer, and that may be due to irritation of the skin. But I mean, we have like we have a cell in the stratum corneum. You should not have that at all. I mean, you can have nuclei and it'd be parakeratosis, but like that's an entire cell. And what we also see here are atypical enlarged cells that do not have like the desmosomes. It's pretty smooth, and this looks like it's forming a gland. So this could be melanoma. This could be, since this is in the scrotum, could be extramammary Paget disease, and we'd have to use IHC to tease out whether it's primary, where it developed from kind of the skin and the glands in the skin, versus secondary, which develops from like metastasis that has involved the epidermis. So let's see here. So SOX10, is it melanoma? It's negative. Is it kind of squamous cell carcinoma? Negative. CK7 is positive. Okay. So, yep, this is extramammary Paget disease. We have those singly dispersed cells that I had mentioned, just mucinous vacuoles, some gland formation as well. If this were positive for CK20, that would suggest secondary extramammary Paget disease, maybe due to like rectal cancer metastases. So we talked about melanoma, squamous cell carcinoma in situ. Mycosis fungoides is a differential. Stable, same with CD4, but not CD8. Mycosis fungoides, you'll have lymphocytes, and this atypical pagetoid cell with the grayish cytoplasm, that won't be seen in mycosis fungoides. Mycosis fungoides, you want to see a lymphocyte that's the same size as a keratinocyte. You want to see dermal epidermal junction tagging as well. And sebaceous carcinoma in situ. We should see some intraepidermal sebacytes if that were the case. So describe the difference between primary and secondary. So we talked about this of extramammary Pagets. Primary is an idiopathic disease usually affecting the genitalia or breast, thought to be of apocrine origin, and secondary Paget disease represents intraepidermal spread from pre-existing cancers like anal squame, rectal adenocarcinoma, or breast carcinoma. Name 5 differential diagnoses for the pagetoid pattern in the epidermis. So there's Paget disease, melanoma in situ, squamous cell carcinoma in situ, sebaceous carcinoma in situ, and mycosis fungoides. Extramammary Paget's disease has scaly red patches, often pruritic, and may be confused with eczema clinically. Usually affects older adults, and Paget's disease is generally cured by excision, although recurrences are not uncommon in the setting of extensive disease. Yeah, that's it for today. Sorry for the sigh. I'm like sighing because of training that we'll have to do, but I'm just joking. Well, I'll see y'all next time. Thank you again to Pathlibrary for this case, and have a good one. Bye.